Palmer from RUH is here on behalf of Tara Charles Banks. So welcome, John, if you've joined the meeting already. Yeah, good. And Lynn Gibson from VCSE is here on behalf of Paula Bennett. So again, if you're here already, Lynn, I'm just having a look. Yeah, welcome. Very, very nice to see you. Are there any declarations of interest that colleagues want to raise that have arisen in the last 28 days since the schedule was last amended? If there are, say so, or anything that will arise in the meeting? No, I don't see any.
Can I just mention something, Rob? Is that okay?
You are certainly allowed to.
Since sending your brief, we also have Laura Ambler joining us on behalf of Aidan Dunn from BCP Council, and Jen Salter will be with us from 1 o'clock from Wiltshire Council. Brilliant. Just some changes. Thank you.
Yeah, no, thank you very much indeed. On the action tracker and the matters arising, are there any items that any colleagues wish to raise? This is usually you, Adrian. I don't see your hand up, so I'm
no, happy to proceed, Rob.
Thank you very much. So we, as our first business meeting, we have questions from the public. We have received one. David Freeman will let us know the question and then give an answer, and that will be published in our minutes online. David. Is David there?
Yeah, apologies, just trying to find my microphone. So, colleagues, the question we've had, Rob, would it be helpful to read out the question, or do you just want the response?
No, if you could read out the question as well, please, David, that would be helpful.
Thank you. Okay, so we've had a question about functional electrical stimulation, FES, which is a treatment used to stimulate movement in weakened or paralyzed muscles. It has been proven to improve the lives of many people with multiple sclerosis, making walking easier and reducing the effects of foot drop, including trips and falls. This allows people to take part in daily living and social activities, as well as feeling more confident and independent. Research suggests that around 75% of people with MS will experience walking issues as part of their MS. Walking problems are amongst the most disabling effects of MS and are the main contributor to disability within the first 10 years of being diagnosed with MS. Walking issues have also been found to have a negative impact on people's employment status and their ability to do daily living activities such as shopping or doing things around the house. Maintaining mobility is one of the highest priorities for people with MS. Keeping people active and in work also reduces the costs to the NHS and social care. FES is cost-effective for healthcare providers, but is not being funded consistently by NHS organisations in the UK. Even though FES has been NICE approved for over 13 years, people with MS struggle to access it. It is not currently funded in Dorset. All other ICBs in the Southwest provide some element of funding, whether it is for adults, children, or both patient groups. The 10-year health plan aims to move care into communities and prevent illness. A community-based FES service in Dorset will help the delivery of these aims. Will you work to set up a funded FES service for Dorset? And there was a link to further information and evidence about the benefits of FES. So our response to that, having looked into it, the Dorset position on funding of functional electrical stimulation was formulated via a pan-Dorset technology review, followed by input from public health on the effectiveness and cost-effectiveness of FES for patients with foot drop. The policy is due for review, and NHS Dorset is aware that we are an outlier in our funding stance in the Southwest. As we form into our new integrated care board across Bath, North East Somerset, Swindon and Wiltshire ICB, Dorset ICB and Somerset ICB, we will review our commissioning policies. This will support consistency of funding decisions where it is needed and to achieve value for money and reduce any unwarranted variation within the new wider ICB area. We are currently undertaking a reorganisation across the 3 ICB organisations, which will result in one team across the 3 organisations who will take responsibility for clinical policies. Once formed, we will ensure they have your contact details as well as the information that you have already kindly provided on the evidence of benefits. And that's the end of that, Rob.
Thanks very much for covering that, David. That's much appreciated. Sorry, just back to my agenda. The register of interest is for noting and has been updated. The company secretary are there any updates on that since it was published, or we can take that as read?
I'm just making some updates to Adrian White's conflicts of interest, because I understand there is some corrections. I don't know if, Adrian, you wish to highlight them any further, but we will update.
I saw that note, thank you. Adrian?
Yeah, no, just there are a couple in there which I think probably have been mismapped in the way that the register's been consolidated as the 3 ICBs have come together, and there's one previous declaration that's not yet captured, but it's previously been disclosed and approved by you. So just an admin update.
Thanks very much indeed. So we move on to a brief update from me, and then I'll hand over to Jonathan for his Chief Exec's update. It was interesting last week, Jonathan will mention that the NHS Alliance took place, and interesting context for us today. We have a new Secretary of State, but I thought the message from the Secretary of State was very much continuity on the agenda that is already in place, rather than a change of policy direction. Of course, we also, are meeting today at a time where it appears that the Iran conflict will come to an end, which hopefully means that energy prices stabilise, and the effects that this is having on our economy and the cost of living. So hopefully some good news there for us in the medium term. At the NHS Alliance, 2 things really struck me, and Jonathan, you might want to build on this. First of all, a lot of interest on how is neighbourhood health set up and made effective. I was lucky enough to chair a session on funding flows and how they will work, and it's at very early days, isn't it? But I think the point I made, that when the tariff was introduced 20 years ago, the idea that activity would be paid for that hadn't been budgeted was anathema, and people couldn't understand or get their heads around how a tariff system would work. And here we are 20 years later, where it's hard to imagine life without it, and it's been difficult to move on in some ways. Well, we're now at the beginning of creating new incentives, and I mention that as coming out of the NHS Alliance conference, because we are at these early stages where, just as it has been fairly automatic that if elective activity took place, it got paid for, so now we need to set a new set of incentives. And as prevention and leftward shift and work takes place in the community, how is that funded? And how do we make sure that we have incentives through contracts that fund that? I was really pleased to see Dorset highlighted in a packed workshop around the work for Macmillan. See you're there, Matthew. Really marvellous to see that work on integrated health that's taking place being highlighted, and of course we've got lots of good practice across the cluster. But the exam question that everybody was raising was, we're grateful to Macmillan for the help, and it helps to set up new relationships and mood trust, but how do we turn that from pilots into business as usual? And where we have seen some, hopefully some better service and prevention made, how does that start to be funded without the help of Macmillan through business as usual and the way that the ICB works with providers in order to shift resources around as that work happens. So that was one thing that really struck me. I think the other thing that really struck me was the acceleration and the pace that's taking place on AI. Lots of good examples of AI really adding value and improving the quality of care, but also creating a new financial model for primary care and secondary care and everything that we're trying to do. And I was just struck, even compared to a year ago, about the sheer volume of the event that was taken up by lots of discussion around AI. So they were my takeaways, which I hope are helpful. Before I pass over to Jonathan, just to formally note that Duncan Sharkey, the Chief Exec of Somerset Council, is stepping down from the cluster board. He'll continue, obviously, to play a full role in the Somerset board and our place arrangements with Somerset Council, but they have nominated Alison Bell, their DPH, to be on the cluster board going forward, which I would ask you all to note. Jonathan, I'll hand over to you. I don't know where you want to start, but you know, they were my takeaways from the Alliance Conference. You may want to add a bit of colour to that, or start wherever you wish.
Thank you, Rob. Thank you. So yeah, I will certainly do that. I was just going to say, just initially, because I think the public question shone a bit of a light on an issue as well. I just want to kind of make that point at the beginning. So the point that the question that David answers around FES, I think is subject to a wider set of issues that we're discovering, which is not unsurprising that there are different kind of clinical policies across the cluster. So it's just to say, I mean, it's a complex set of things that we need to work through. But as we get the team in place, we will start to prioritise that and work through those clinical policies in a structured way to start to give us some clarity and some consistency across the cluster. So I just wanted to kind of comment on that initially, because it's a good question, but I think it's part of a kind of wider set of work that we need to do. Just in terms of the kind of alliance and the Confed Expo last week, I would absolutely agree, Rob. I think that the two big themes were neighbourhood health and technology, and I think certainly as I sort of wandered around the expo, I think the thing that struck me was the number of stands there that were various technology companies describing what the future looks like, and the future actually being quite different from what we think of today. And even if we're just talking about the idea of ambient voice technology or AI, that is running at such a pace that the opportunity is always kind of going to be ahead of us. And I think by going and talking to some of those organisations about what's on their agenda and what they're thinking through, you get a sense actually of the scale of the radical transformation, which isn't just about listening to consultation and being able to use ambient voice technology to deliver care in a different way in the interaction between kind of patient and clinician. It can actually they're thinking about how it fundamentally changes the way that we deliver care to the population. And I just kind of linking that back, because one of the things that I referenced in the report was I think where I've got it in here, it talks about NHS online hospital. And again, Bernie and I had an initial conversation with the folk that are starting to set that up. It's been set up as an online NHS trust. And the media that came out was very much about the appointment of the chair. But actually the opportunity is significant, and I think it is a big disruptor potentially. We need to see how it pans out. But essentially they're looking at 4 elective pathways in the first instance: so ophthalmology, gastroenterology, urology, and gynecology. And essentially what would happen is you can access those services by through the web, through the NHS app. Book an appointment and a consultation online with a clinician who is made up as a sort of network of clinicians from across the country. It might be semi-retired folk or people working part-time but giving up sessions into the online hospital. They will then access diagnostics through the local diagnostic treatment centres, and then you have your follow-up with them. There's a bit of a question when we got into it about the entire pathway and what happens for those people that need surgery, but certainly for those conditions where you manage all of this in outpatients, and they were very much thinking about therefore how they partner with private sector organisations and with NHS Trust to deliver the surgical element of it. But there's two elements really: the path, getting that pathway right, and actually also fundamentally working out how you commission it. And part of the conversation that we've been having with them, and we will have on an ongoing basis, is that question about commissioning. But if you think about that as an example, that could radically disrupt our outpatient model in its current form, and it will require a response from providers actually to enable different care models. So you've got that sort of thing going on, and then you've got some kind of very radical AI type solutions which could be implemented at the front door of general practice through telephony, using kind of online online and AI type tools to triage not just administrative type arrangements, but actually simple clinical queries as well. And the potential for that to be able to remove a whole heap of work in a very standardized way from the general practice day-to-day workload, and enable people to focus on continuity and long-term care is significant if you can get it right. So I think it was the Confed was rightly focused on technology, and I think there's something for us as a cluster to be at the forefront of that, and not only just be thinking about how we use technology in our day-to-day life, which is always slightly reactive, isn't it? Because you kind of get on board with it at a point at which you kind of know something about it, but how we actually put in place some meaningful partnerships that start to enable us to think about what this could actually look like in the future with some of these organisations that are at the forefront of the development of it. I know there'll be a set of views about the use of technology, but it could be significant. The other thing that I was going to say was, I suppose linking back into your point, Rob, about the Secretary of State, and just listening to the Secretary of State's speech on the Thursday. I mean, the key takeaway for me were, again, probably two or threefold. One was a message that the plan is the plan, and there's not going to be a kind of radical departure from that. But I think a challenge around pace, and he talked a number of times again about technology, but how tomorrow's solutions should be the solutions to today's problems. So I think we might see kind of a narrative which is around increasing the pace of change, and trying to bring the solutions of tomorrow forward, to try and address some of the problems of today. So again, my big take home from him is a focus on technology, but a focus on pace, but not a radical departure from the plan, which I think is helpful in that sense. I just see Matthew's hand's gone up. Matthew,
Matthew's got his hand up. Should we bring Matthew in and before the rest of your update? Matthew.
Yeah.
Thank you, Jonathan. Sorry to cut across, and your update and Rob's updates are very, very helpful. I was just thinking about the point that you made about AI and partnerships, and I suppose that potentially within the cluster we've got the opportunity to look for those partnerships at scale over a really interesting area with some innovative work being done. And I don't think we need to answer this question today, but I guess there is a question, which is how do we do that, and sort of what are the various roles, including the role of the strategic commissioner in facilitating that and enabling that to happen. And I think it would be helpful perhaps to do some thinking about that and come back to it, because I too think that there is a real opportunity there, and probably a bigger opportunity to act together in some of this than working separately.
Yeah, I mean, I don't know what this feel, but I that was my take out from this, Matthew. I think we sort of need to be coordinated, but we need to be forward thinking as well. We've all providers and commissioners are going to have different roles in this space, but our ability to commission in a way that incentivize that kind of the move to digital solutions is something that we definitely need to be thinking through. But I think we need to move together, and we need some sort of partnership with some people that are going to open our eyes here to what the art of the possible is. Otherwise you're just reacting to the thing that we know today. But I think it needs some further thought. Matthew, absolutely agree.
I mean, if I can just add to that, I think what I see in a lot of business media is two levels of working on AI. One is to have projects and partnerships, and specifically to have some ambitions, but then secondly, to equip everybody to have AI skills. And in a way, 1,000 flowers that bloom, and by equipping people with tools and skills, you unlock the potential, but quite a lot of concern about the cost of doing that. And already a number of sectors realise that they're spending a lot of money on AI without necessarily getting a return on it. And so I think we have to keep our eye on all of that, if that makes sense, Jonathan and Matthew, that we are doing this for reasons to get benefits realisation. And that the experience of other sectors is that there's a little bit of a question mark about the degree to which we can afford general skills and general tools which are becoming costly for people. I hope that's helpful.
Yeah, definitely.
And I also see Addy, your hand is up. Well, let's bring you in, and then Adrian, and then we'll get back to other things that you wanna brief on, Jonathan. Addy?
Sorry, Jonathan. It seems to we've all hijacked your very interesting update on there. I think I was just going to highlight this or flag up the opportunity that actually have come out from the two updates we've listened to so far. One is the neighborhood health one, and actually the emerging new technologies such as AI, and how as a cluster actually we do what is how we can or how we should be thinking about using it to meet some of the challenges that our rurality in the broad span of our geographic expanse presents, but also to actually bring people closer to the NHS, which is always the sense of those, particularly with the deployment of technology. It creates another barrier, and I'm just thinking, or maybe asking us how far our thoughts are actually in terms of almost using the making sure that as we do have a very good sort of pathfinder work in the neighborhood health work, we are also then pairing that up, because it could really get us to continue to lead and show how the technology actually enables closer contact, and in some sense there. And I'm wondering where, if not now, maybe it's a work stream that we just need to make a note that this is our opportunity to really help to do this, especially with our geographical footprint.
I'll bring in Adrian, Jonathan, and then back to you, Adrian.
Thank you. It was a separate point, Rob, but just in terms of talking about AI, you mentioned what you're reading in the trade press. There's quite a lot around at the moment around the things that boards should be asking themselves with regard to AI. It might be worthwhile just separately asking the teams to bring that back as a topic. And there's a lot of focus on data security and the environments within which you allow AI to operate, and also guardrails around things like having human in the loop for certain degrees of risk categorized AI use cases.
Thanks very much, Jonathan. I'm going to bring in a couple more, and then we'll get back to you, because let's hear from Caroline and Carl.
Yeah, I think there's lots of opportunities with AI, and I suppose it's just that recognition that whilst that might help the majority, we must be mindful of those that it won't help, particularly in the healthcare sector, I think, where we have some vulnerable people who might be disadvantaged by it. And just thinking of Adrian's point on the dangers, talking to a local group recently, people are very worried about things like online scams and so on. So we just need to think about that vulnerable group and how we access them.
Yeah.
Thanks very much, Carl.
Yeah, thanks, Rob. I just typed in the chat earlier, just before Adrian's point there about governance being important. I think I've got a couple of board briefing papers on use of AI, which if I dig them out, I'm more than happy to circulate those. They might be of interest.
Well, they will be, and let's take it as an action that we think about board responsibilities on AI and making sure that we bring that back in the way that you and Adrian have discussed, and then substantively as well, looking at the use of AI in our commissioning and across the cluster. So we'll think that through and deal with that properly. Becky, your hand is up, and then I'll go back to Jonathan.
Just really actually partly to respond to Caroline's point about vulnerable people. I've just come from a meeting where some of this was discussed, and they were talking about you know, a practice that's part of the PCN pilot in the country, where they've revolutionized their call handling. And one of the things they've done is using AI, whereby the majority of people are asked to do their triage online, and can in fact even go to a digital assistant will fill it in. But those people that they know are really vulnerable, those phone numbers are all known, and those are taken off the top. And if any of those phone numbers call in, all those people automatically go to a human straight away and don't go into anything else. So it can be flexed to do that, to make it really work for the vulnerable, that they get taken off to talk to a human immediately. But those people who can cope well and fine with a digital system can, just use that system.
Yeah. Thanks very much, Jonathan. I hope that was helpful.
It's really helpful.
We'll find a way of coming back to the governance issues, and that they can be considerable around data, but also substantively the use of AI. Useful to come back on both.
And I think the just the debate that stimulated suggests, this is something we need to come back to, and we need to have a kind of really clear approach to it. I mean, just picking up kind of Becca's point, some of the technology I saw, actually what it does is it sits in the background. It's not dependent on you using technology in a way to, some of it was happening through a kind of phone call. So it wasn't about you having to be online. I think some of the companies that I was talking to, the point about digital inclusion was definitely something that was on their mind, in terms of how do they support some of these tools to not widen inequality. But I think we need a clear approach, don't we, to this, and we need to have clear governance around it. And I sort of think we need to have some sort of partnership that enables us to think some of this through. But let's take it offline and kind of bring some proposals back. And Carl, if you've got a couple of papers that you could share around the governance element of it, that would be really helpful, because I think it would further our thinking.
Yeah, and Carl, you're useful if you could give us any thoughts around research as well. I'm involved in the university sector, and actually our researchers, including the medical school where I am, are keen as mustard to use AI tools, but there are quite considerable information governance issues around the way that puts national health data potentially outside of our control. And so do we limit those tools or not? And so some thoughts on that, Carl, would probably be useful to everyone.
Yep, okay, we can do that.
Thank you. Jonathan, back to you.
Yeah, so just a few other things. So on the neighbourhood front, I hope, you've probably got a sense from the report, and particularly when you go down into the place elements of the report, that there's a lot of work going on trying to now get consistency in terms of things like geography of neighbourhoods, and how that's kind of working in through kind of local place-based arrangements. And then I made reference in the report to the work around neighbourhood health centre plans. And again, I think for us, we were asked to fill in a submission with a prioritised kind of set of schemes, probably slightly before we were ready, because we hadn't kind of had enough conversation across the cluster. So we put in a submission. It's an initial submission on that basis, and we need to kind of now work through places and with partners to consolidate that and kind of do the detailed planning. Just a couple of other things. I think the other theme was the piece about the King's Speech, and I've tried to pull out the main points there. I think for us as an ICB, it does formalise our future commissioning arrangements, and those are not just pharmacy, optometry, dentistry, specialised commissioning for all but the very, very specialist stuff, which is going to sit at NHS England national level, health and justice commissioning, vaccinations, immunisation and screening as well. And the working assumption is that our ICB cluster hosts what's being called the Office of Pan ICB Commissioning, effectively our kind of commissioning hub for the Southwest, that does, on behalf of the 3 ICBs, the work in those delegated areas. So again, Alison, David and I and others now are having some very active conversations, which will bring back through appropriate governance around all of that, to make sure that the ICB cluster inherits the right resource to enable us to do that job well. And so I'm sure coming through committees in future, we will need to have oversight and assurance of that. I guess just a couple of the other things that were in there. Obviously, this is all subject to the bill progressing in the form that it's in at the moment. But the abolition of integrated care partnerships, a change in the membership of ICB boards, particularly from a partner member perspective, with a strengthening of the voice of the mayor in there. Again, we've got a paper in part B around footprints and alignment with mayoral authorities in the future, but you can see that sort of change potentially coming, and the implications for Health Watch as well, which I think Kim might want to kind of comment on that, but I think for us in the ICB at the moment, it's not really that clear. There's been some statements that have kind of been made as part of the bill, but we need to see how that progresses. The other couple of things I was just going to say, one is related to the ICB change process, and again, you've got a brief update in the report. I think that probably belies the amount of work that is currently going on, and certainly will now happen over the next 6 weeks. So essentially where we've got to is we have confirmed our future structures. We issued letters last week to all of our colleagues, informing those people who had been matched into roles in the new structure that was the position for them. Everybody else remains at risk and is now subject to a process of expression of interest into those roles and competitive internal interview. I guess the consequence of that is that probably for the next 6 weeks or so, we will be interviewing upward of 400 people for roles, which is a significant ask. It's good now that we are starting to get some of the reports, the direct reports to directors in place, so those people can start to help. We will cascade that over the course of the next few weeks, but it is a monumental task now, the actual recruitment process. We aim to get that complete by the end of July, so people have said to us, let's just get this done now. I think that's where we are. We want to do that as fairly, as transparently and as openly as possible, but it is a massive task over the next 6 weeks or so. So there is a bit of a question about, just bear with us, because I think people will be doing not a lot else other than interviewing over the next period. And the other thing on that, just to pick up, I know we've had a conversation both through the transition committee and through the board about strengthening the governance arrangements around that transition and around that work. And Adrian, thank you for the conversations you've had in the background. We are working up what we described as a control document, which will highlight some of those risks in the transfer of the kind of current process to the new process. And again, we will bring that back through the transition committee over the next few weeks. That work is now happening at pace, and actually by having some folk now at the deputy level, that is really helping, because those are the people that are kind of closer to some of that sort of action and those risks. The couple of other quick things. One, congratulations to Matthew and to Dorset Healthcare for being successful in their AFT application. So we'll work with Matthew and the team and Siobhan as well in Dorset around the implications of that as we move forward into the future. So that's really positive, I think, for both the Dorset system and the cluster. I wanted to note it's really good to have Lynn here today, Lynn Gibson, but we had a really good conversation with the VCSFE sector across the whole of the cluster, and as Rob said, have confirmed Paula Bennett, who will be the VCSFE member on the board, but with deputisation where Paula is unable to be with us. And then just a quick few things just to pull out the place updates, which I hope are starting to bring to life. We've purposefully now put in a VCSFE update, which Paula helped pull together. We're going to try over time to make sure that that is more integrated into the place-based updates, but we've just got a single update there for the VCSFE. I'm just pulling a few things out from the place updates. As you said, there's a lot of information about how each of the places are moving forward with their neighbourhood health work. We've got a further visit from Claire Fuller this week. Claire seems to be on a bit of a road trip, which keeps coming back to us. We hosted her a couple of weeks ago in Somerset. She's back in Somerset again, looking at the pilot test pipe site in Frome and Mendip this week, and then she's back again looking at the rest of the cluster. I think in the middle of July. Really good to see the opening of Trowbridge Integrated Care Centre. Official opening of that is on the 26th of June, and you'll see the updates on the Somerset Stroke Pathway dentistry in Somerset, where the third dental practice has been opened in recent weeks, and the reopening of the Yeovil Hospital maternity service. We've got the SEND reform plans that are coming back later today for support. So again, thank you to the teams that both across the ICB, but actually being led by colleagues in the local authority, Herculean task to get that all in place in the required timeline to support the submission. And I think, and then finally, we are working with Siobhan and the team and UHD around the potential delay in the transfer of services between Poole and Bournemouth due to the delay in the building works on the Bournemouth site. So I think the board kind of noting that would be helpful. Some further work in terms of exact timelines and what that means. Rob, that's a quick canter through quite a lot that's going on. Hopefully helpful. Yeah, happy to take any questions.
Very helpful. Jonathan mentioned the strategic ambitions item, which we've got next on the agenda, so hold any comments on that. And Jonathan also mentioned the footprint discussion in part 2, as well as the SEND discussion. So I'll ask if any questions on that can be delayed. But is there anything else that colleagues wanted to ask about? Chris.
Thanks, Rob, and thanks, Jonathan, for the report. Can I ask a little more about neighbourhood health? Clearly, a very important strategic area for us. You mentioned £50 million of government funding for neighbourhood health centres, for 27 of them. Roughly speaking, that's one being funded for every ICB in the new configuration, but not us. Is this a disappointment that we haven't got such funding? Is it hampering our progress? How does that work through in your view? Thank you.
Thank you. Jonathan.
Okay. So I think so. The first tranche of money was kind of announced prior to the work happening. So you can do the maths, Chris, and say, well, we've got 27 and they should be, that's one in each ICB. The reality is that's not where they landed. I think the majority, although 50 million sounds like a lot of money, the reality is a lot of these were sort of small scale change to existing facilities. So they're relatively small kind of grants of a couple of £1 million for so rather than whole kind of new builds. So I think in a way, you can see there that Bristol and Cornwall were recipients in the southwest, but nobody else was in that sense. So I think in a way we probably kind of like that is what it is. I think the opportunity actually is for us to think. So two things. One is, through this process now of putting in expressions of interest, we need to be able to refine that and get to a point where we've got a clear level of prioritisation. So if and when a second tranche of NHS money comes, we're ready to bid actually for something, and we know our prioritised order. I think the other thing it did strike me was we also don't need to be a slave to national capital funding with this, and thinking through different ways of being able to partner once we've got a clear set of priorities. I think is an important other thing to do. So I don't think all of this is going to be delivered by slugs of NHS capital alone. And certainly, I think listening to the Secretary of State, he was, the question was asked, well, is there more capital monies coming? And he sort of slightly evaded the question, but he did sort of say, well, if there is, I'd want that to be going towards technology rather than building. So I think we've also got to just think differently about how we might partner to deliver the sort of funds that we would need. I don't know, David, others, whether anybody wants to come in on that, but it's just a kind of personal view.
Well, I'll bring in Dan there. I mean, I guess what we need to do, Jonathan, it's a good question, Chris, is keep a helicopter view, Jonathan, rather than sort of respond to piecemeal opportunities. We need to keep a helicopter view of how are we investing in neighbourhood health and what's happening across the cluster, and to discuss that at high level, so that in a way we prioritise where we think interventions are needed. If that's helpful. I've got Dan and then Kim, and then we'll move on. Dan.
Thanks, Rob. Jonathan, thanks for the report. If I can, a comment and a question. The comment was, I was just thinking about AI from a morale point of view. And clearly people won't be thinking about this because they're in the process kind of competing for their jobs.
Yeah.
But to what extent have you done any thinking about how settled this op model will be? When will it change again? What impact AI has had, will continue to have on it? Because at some point there's going to be a question, isn't there, about ROI and AI will mean releasing some payroll costs, and just interested if that's coming up. And then a question. Yeah, congratulations to Matthew. I was thinking about that from a commissioning point of view, and the footprint of DHC across the 2 Dorset places, and hope I get my acronyms right, AFTs, IHOs, and how all that works for us as a commissioner. And my question, how are we governing that to make sure we capitalise on the opportunities, of which there are many, and manage risks? Because that feels like quite a big shift that personally I don't know an awful lot about. So I'm thinking about organisational governance around maximising the benefits from a commissioning point of view.
Thanks, right. Let's take Kim, and then Jonathan, you can come back. Kim.
Yeah, thank you, and thanks for letting me speak. Jonathan, obviously in response to the abolition of Health Watch in the bill, and just trying to seek some clarification about where this group sees itself. So does this group see itself giving that future direction across the cluster to achieve the obligations to understand the patient experience, or does this group think that that will be a cluster-based decision?
Jonathan.
Yeah, so Kim, that's a really good question. I think I mean, we see our role, part of our role, as having kind of deep roots down into communities through place and through our new engagement kind of function. I think the honest answer is we want to work with you to understand the implications of all of this and where kind of Health Watch and the future of Health Watch might sit. Now, a lot of what's been talked about is Health Watch national, isn't it, rather than kind of local? But obviously there's an implication. I think it's early days, and I honestly think we just need to get around the table. I guess the one thing we can say is that those connections into communities in its broadest sense, and particularly those that have traditionally been hard to reach, is something that's very much on our mind as we develop our approach to engagement and co-creation with the population. But Sheila, I don't know whether you want to add anything particularly. You don't have to on that one, but I just think we need to have a conversation, given that there's a direction of travel here, and we need to work it through.
Yeah, I'd love to pick up a conversation with Kim outside of here. We said hello at previous meetings, so and it is just working out where we get all of that insight, engagement, etc. From and from other organisations who are also collating a whole load of insight and engagement material. But yeah, Kim, let's have a conversation outside of here.
Perfect, thank you.
And then Jonathan, maybe come back on the AI point at another time about how we equip people to have skills, because we've discussed that earlier. But Dan's question about AFT, well done, Matthew. What follows next, the integrated health organisations, is a contract form, not an organisational form. And I guess, Dan, if I understood your question, it's how we're going to have the governance that we make sure we introduce IHOs in the way that meet our commissioning priorities?
Yeah, and again, I think the answer to that is you need to work it through, but it's a job of the. I mean, so we're going to come on in a moment and talk about our strategic ambitions document, aren't we? And we've said in there that we want to support the development of, well, we said two IHOs in the cluster. That was kind of, we need to work through that in its own sense. But I would see the commissioning committee as having a really clear role in the oversight and assurance of all of this, because on a number of fronts, there's the kind of bit about, well, what does the contract look like? And again, some of the work that Alison's starting to get involved with at a national level about payments and outcome-based arrangements need to feed into that. But so does the thing about, well, what does it mean to be an IHO? What does that mean from a commissioning perspective in terms of our delegation of certain kind of functions into an IHO type arrangement? But the short answer probably, Dan, is the Population Health and Commissioning Committee would need to oversee all of this, and we would need to take it in a structured way. We need to have some sort of way of being able to make sure that there's the right capability and the right capacity in place to catch some of these things at that point. But I think that's why we sort of said we'll start off doing some stuff in shadow form and try and work it through with providers.
Yeah. Well, look, let's move on. That was a really good update, but also a really good discussion. And we're going to have to hold ourselves, aren't we, as a board, that we come back on these big ticket items in a helicopter and structured way. How are we doing neighbourhood health? How are we utilising the opportunities of AI? How will we let contracts that utilise the opportunities of integrated health? And we need to make sure that through the committees, but also through the operation of this board, these are the big ticket things that we give a lot of focus to. So I thought that was a great discussion. David, over to you. Yeah. We've obviously read the ambitions document. You might want to say a few words, and then I'll open it up to questions and comments.
Yeah, thanks, Rob. I think there are sort of a handful of important things to say around this for clarity, especially for colleagues who are coming to this for the first time, potentially some of our new members to the board, and any members of the public who might be listening. I think it's really important to set this in its correct sort of setting, its correct context. And also, I think, linking the previous conversation, I think, the importance, Rob, as you've just been saying about, it's our job to identify priorities, set the strategic direction and the ambitions, and we would then use the mechanisms of integrated health organisations or other contract forms to deliver and make sure those things deliver on the ambitions to contract the activity that we need to get to the points we want to get to. So this is a bit of a crossover for that. So let me take you into it then. So just for absolute clarity, this work was, the need to carry out this work was prompted by a call from NHS England to each new ICB to describe the extent of our ambitions for change as part of delivering the overarching NHS modernisation agenda. The work described in this report builds on a combination of the plans that we have collectively discussed and agreed during the 2026-27 planning round within each of our ICB footprints, and then subsequently from a workshop discussion at a board development day on the 7th of May. In line with the national ask, but also because we already have clear ambitions for change, we were keen during those discussions to collectively stretch our thinking to see if we could go further, faster, and in so doing to capture these stretch ambitions as SMART goals. That is, specific, measurable, stretching but achievable, realistic and timely. So we wanted to put some concrete direction behind them, just to sort of give it a bit of a shove in the right direction. What's important to say is that this work does not constitute the strategy or an agreed plan for the systems within the cluster footprint. It isn't, as Jonathan said, it's intentionally articulation of how far and fast we might be able to go in the delivery of the 3 shifts and the 10-year health plan ambitions. So for all the work that's been going on, we absolutely remain committed to working with our public and our stakeholders to develop a population health strategy and a set of priorities. The plans set out in the paper that we are discussing today are not a replacement for that work, and I think it's really important to lodge that in at this point in the discussion. Notwithstanding that, the work we've done will provide a brilliant guide in those co-design and engagement discussions, and thus enabling us to be as ambitious as possible. So this paper brings together the planning work, the workshop outputs, because this is the first time we've had a chance to consider that, although we did have a conversation about it in the Population Health and Commissioning Committee last week. And this, as you've got in your papers, you've got a write-up of the workshop outputs and then the final version of the submission we put into NHS England. And with your permission, Rob, I've got actually, thanks to some brilliant work from Amanda Webb here in the board, we've got a plan on the page, which I'd like to test with you, if that's all right, because apart from anything else, it summarises the, here we are, let me just bring it up, folks. It summarises the ambitions, the SMART goal ambitions, but also to the conversation we were just having about the process by which we will get to our delivery mechanisms. So I refer to these things as commissioning pathways. So the contracts that we will set in the end are the output of some previous work. So here we've got a kind of a house of transformation. We want to deliver 21st century health, a health and care system across our 3 footprints by 2030. And moving away from incremental change, which we've been trying to do over recent years, to a big step difference in a system that's built around people, prevention and neighbourhoods. And the approach we take, we've got a 5-step approach to getting to there, what the building blocks are, a population health insight that then informs a population health strategy that then informs what we do with commissioning, and the different methods and models we might take to achieve those outcomes that we've identified through our analysis. And then, of course, it's delivered with integration and our absolute commitment to do this through a neighbourhood-based model of care with multidisciplinary teams and multiple partners around that. We're looking at not only health needs, but also wider determinants of health. And then the final stage, which if it was a cycle diagram, you would see closes the loop, which is, are we having the impact that we need to have? And if it's not having the impact, what can we do about it? That is the model, I think, as Dan was trying to get at, is if an AFT has been approved within our footprint, what does this mean for us? Well, actually, what it means for us is it's a brilliant opportunity for us to accelerate towards our ambitions, because it's a necessary step in the current guidance to let an IHO contract. You have to be an AFT beforehand, and so for us, it's a real boon. It's a real opportunity to do some building, but it has to be for us. Function follows the form. Yep, sorry, the form follows the function. Yeah, and so we've got to make sure that that it's the right thing to do to achieve our aims. Right, just very briefly then, if I can take you here. So in the pack, and this is summarising, these are kind of the 3 areas, 3 years sort of ambitions that we've set out for ourselves. And as you can see, by the end of year 1, I'm not going to go through them all, just to give you a sense though. By the end of year 1, we're going to we've committed to try and deliver these things, define our priority cohorts, strengthen our commissioning capabilities. By the end of year 2, we're working towards establishing 2 IHO contracts and growing a transformation fund. And by the end of year 3, we want to have established our 47, as it's currently counted, integrated neighbourhood teams, and over 50% of our contracts will be outcomes based, and so on. So I was saying earlier about there being SMART goals. So the timing is across the 3 horizons, and the measurable goals are these objectives that we've set out here. And then, do we know if we're having the impact? What are the things we're going to look out for? And those are outlined there under the measuring impact statements. So I'm really grateful to Amanda for pulling this together. It's quite a complex thing to do with that long document as you've done, and I think she's done a fantastic job. And so I can't claim any credit for it, which is I'm passing it over there. But it really does summarise where we've got to, and the outputs of our workshop, and it's the totality of our commissioning and operating plans across the for this year and going into the next 2 to 3 years. I wasn't going to say much more than that, Rob, because I thought it was important to orientate people into it, just to certainly if people haven't seen it before and weren't involved previously. but also to remind ourselves where we've got to and what we're going to do about it. The final thing is just to reiterate that point, although this looks like, and deliberately sort of provocative to try and pull it together like this is not a plan yet. These are ambitions, these are guide rails for the ambitions we want to do. There's plenty of detailed work to be done and lots of conversations to be had before it becomes the plan and becomes the strategy. Okay, I'll pause there.
Well, thank you, David, and thanks to you and Amanda and everybody, because it's really good to see that the output of our strategy day has led to this output. And I really like the plan on a page as well, because it's good that before we get to delivery and holding ourselves to account for delivering those milestones, we get to see the totality of it so that we can iteratively discuss, are these the right ambitions and is this where we want to go, so that we have complete buy-in on it. So I think this is real progress that the strategy day has led to this output already, and thanks very much. Are there any thoughts or comments, or are you happy to take all of that as read and then we go to the next iteration? Anything from anyone? Adrian.
Thanks, Rob, and thanks, David. Just to share a little bit of the discussion we had under Chris's leadership at the Commissioning and Population Health Committee last week. I mean, I think we also liked the way that the strategy shaping has kind of come through. Rob, there's nothing in there not to like. I think some of the thoughtfulness we had was just around how this does then turn into a set of actions that deliver benefits to our patient population in each of the plan years, rather than it just being, if you like, a 3-year view of build the foundations, get a bit better, and then get ready to do something. And we demonstrate benefits in 3 years. We're just kind of a bit restless, really, for what happens in year 1, what happens in year 2, what happens in year 3, that people will notice beyond the board, I guess.
Well, that's a helpful challenge, David, isn't it? To think about, are there deliverables that we can phase in that way? I hope that's a helpful comment.
Yes.
John.
Thanks, Rob, and thanks for the presentation. I've seen some iterations before that were also really helpful, so it's good to see it getting summed up, and I also like seeing a plan on the page. It's great. I think the one test, I wouldn't say it's a challenge, it's a test, because we're all part of continuing to generate the development of this plan and get the rubber to hit the road at a stage in the future. But I'm just looking at those top 5, 1 to 5, starting with population health insight and measurable outcomes and improvement on the other, and then looking at the 3-year delivery plan. And I think there's a slight risk that the 1 to 5 is content heavy and the 1 to 3 is process heavy. And it's going to be really, really important for us that that this work is meaningful and it has a genuine impact on delivery. So I'm just thinking about who we might partner to help us flesh this out as we go, to make sure that the content's right. So I think we've got some marmot relationships across our patch, and I just wonder whether the Institute of Health Equity might be an organisation that we want to be working with as we do this kind of work, because I'm very, having had a Welsh background, I'm very cued into inverse care law and Julian Tudor Hart and all that sort of stuff, but I think that might be helpful. And then just countrywide, I think Denmark, New Zealand and the Netherlands all have something to teach us about how strategic commissioning frameworks develop over time. They've all got slightly different flavours, but they are generally in population health, digital infrastructure and shift to community. So some of this challenge that we're taking on in NHS England has been taken on in other places previously, and there's a body of work and evidence to grapple with. And the final thing I'd say is Canterbury in particular. I mean, it's a bit of a trope because if you look at New Zealand, you probably look at Canterbury, but their whole approach to one system, one budget is fishing, I think, in a similar pool to us, and it's quite mature. So I think it's a really great outlined strategy. I think the test is how quickly can we move, and borrowing from other places and maybe partnering with other organisations might help us move quickly together.
Good comments, thank you. Matthew, and then I'll come back to you to finish, David.
Great, thank you. I think that looking outwards that John has just prompted is really helpful. I think the document is great and is a good distillation too of that day that we had together as an ICB board. The one page summary I think is hugely helpful. The kind of just two instant reactions I've got to it are, one is on the 5 things, I think somewhere in the strategic commissioning or the integration, there's something about realignment of incentives and almost market reform. We're going to end up, I think, with a changed way in which we provide, and that's in there implicitly, perhaps with the reference to IHO, but there might be value in making it explicit. And then my second point, which is just a gut reaction, others may disagree, I think it's a really good document, but that heading at the top, delivering a 21st century healthcare system, we're 30 years into the 21st century. And I think somehow there's probably a different way of articulating the extent of our ambition for the population that we serve.
Okay, very helpful. David, did you want to comment on any of that, or we can take those comments as read?
Well, and I'll be brief because I think it's helpful so just to acknowledge all the comments. I think really helpful, and we'll take them on board. It is important, and I know I said it a couple of times, that this isn't the strategy. This is just, we were asked to sort of, what would we do? How far could we go? How fast could we travel? Ask from the centre, well ahead of where we wanted to be, because we would have taken the time to do the work on our kind of areas of focus, using the analysis, needs analysis, deep dives, inequalities, all the rest of the things, which we will do. But this is going to provide a helpful guidelines, guide ropes for doing that. And I wouldn't be surprised if a number of things we've already said we could try and do would appear again. But we do need to test that before we get fully behind it with our broader stakeholders and certainly with our public. So we need to run this in a twin track way, and I just wanted to re-emphasize that point.
Thanks very much. Thanks for those comments, everyone. Really helpful. So we move on to the committee reports. We've got about half an hour. I do want to finish at 2 o'clock, so everyone's help on being crisp but thorough would be appreciated. Dan, anything you want to highlight for us beyond this morning's meetings earlier on?
Crisp but thorough. We've not had one yet. We had our first one this morning to approve the accounts that went through to the board. It's coming up in a couple of weeks.
Crisp but thorough. Thank you, thank you very much. And again, well done, for all the work that went into the earlier meeting and signing off the sets of accounts for the 3 legacy bodies. So then we come to the Joint Finance and Resources Committee. Adrian, you'll hand over to Alison and/or cover the cluster finance report and anything that you both want to highlight to us. Adrian and Alison.
Thank you. So we moved quite quickly through the committee update. It was the first meeting of the committee, so a lot of it was administrative in terms of reference, and most of the papers were presenting actuals booked to budget at this early stage in the financial calendar, Rob. So there were no particular exceptions for us to focus on. We did spend and invest some time really getting the committee reset around an understanding of the enlarged perimeter of the cluster, so that we are kind of ready to contribute really as the year develops. But perhaps best to hand over to Alison and the team to take us through the month financials.
Thank you, Alison.
I think you've done a great job there, Adrian. So just in terms of picking up what Adrian said, there's a few slides within the pack, just confirming for month 1 we're on track in terms of our delivery, both in terms of our in-year position for month 1 and our forecast position. But we'll do a lot more deep dive check and challenge as we go through the committees.
Thank you very much. Are there any questions, please? Can I ask a quick question? I know I've said be crisp and thorough, and now I'm asking a question. now that we're not managing a system budget, it's obviously really important that we understand where the providers are with relation to the way we're commissioning them. What we don't want to happen is that late in the year, there's suddenly a dispute arises about what's being commissioned, which could easily happen under the new system. So really, it was a chance to check with you, Matthew and Siobhan and John on behalf of BSW and for all the trusts that you're happy with what you're getting commissioned at the moment. And I suppose this is a coded way of saying we're not going to get something arise suddenly later in the year where you say we think we're being commissioned incorrectly and that's affecting our financial position. I think I'm going to ask this every time we have a meeting to just make sure that we're all on the same page. So is there anything that the providers want to say, or are you happy with what's being commissioned? Adrian, and then Matthew.
Can I go after those you've asked?
Matthew.
Okay, I was hoping to hear Adrian's wisdom. What I would say, Rob, is I fully understand the construct that you're setting out, and it is absolutely correct in the way in which we need to work together. I think that it is we're in the early stages of creating that new relationship together, and we need to keep working through the issues. You know, there are some. So, for example, taking it right down to an organisational position for Dorset County Hospital, we've got evidence that we are very busy in our emergency department, so that contract is overperforming. And as part of the budget setting, we had flagged that we thought that effectively there would be more emergency activity than was the view of the commissioner. So I think we've got some issues that we need to keep having a conversation about, but fundamentally the principles that you've outlined are how we need to work together.
Thank you very much. I'm going to take John and then Alison and Jonathan, and then I'll finish with you, Adrian, if that's all right, because I think some of this will rest with the Finance Committee to make sure that we keep on top of it. So John, and then Alison, and then Jonathan.
Thanks, Rob. I suspect if you asked any organisation that's got a really major deficit challenge, then it's difficult to say we're happy. But I think, as Matthew said, that the framework is improving, and I think it's really positive to have a clear, genuine, strategic commissioning framework, and I'm sure we will mature into it. That I think we are still struggling to a degree as a system with some data deficits, so there is some work to do on that front. But I think we all know that from every organisation that's involved in the system. So more work to do on that front. We will get better, and we'll certainly get better as we move into an EPR platform that's recognisable across the entirety of the group. There are recurrent issues, and Matthew's named a couple of them. So when you're an organisation or set of organisations that's in recovery, then I think you're going to find that there's probably a gap between what we project in terms of commissioning and then what actually happens, particularly when we're moving very fast to catch up. And so we've got gaps on elective and non-elective at the moment, which I think are a feature of the moment in time that we're in. And then high-cost drugs unavoidably features in many conversations, and I think because it's so dynamic as a national set of issues, as well as a regional and local set of issues, again, it's a bit unavoidable, but I think work to do in terms of narrowing the gap on that front. And then finally, I think as we mature, what's also happening is that the strategic commissioning framework is simplifying some commissioning relationships. So we find ourselves at the moment struggling with the unwinding of some of the subcontracting relationships that have been with some of the providers, and we're unpicking those as we go. The important thing is that what we don't lose is the right support for patients during transitions, and transitions have to be managed really, really well, very openly and transparently, and still a bit more work to do on that front. But I think it's a good direction to travel.
Thank you very much. So Alison, Jonathan, and then Adrian, any final thoughts from you? Alison?
Yeah, thank you. I just want to say, so we did take the trust position to the committee as well to make sure that the committee has oversight in terms of that. The other bit is the contract value will be what's holding us together as we go through and move into pay more on a payment by results basis. As we pick up any over performances, then that will flow through the money as well, and we'll bring that back. So there's a need to bring the sort of performance finance elements together in the committee. We haven't got month one data yet in terms of the coding, so as soon as we get that, we'll take that back through the strategic finance and resources committee as well.
Thanks very much. Jonathan?
Yeah, well, I was just going to say your question has prompted a good debate, but I think in reality, from where I am, the relationships are really important with this, aren't they? So we've got new roles in the system, and we're working through to try and work out, what's our responsibility as strategic commissioner versus the responsibility of the NHS England as the oversight and assurance body. I think we've got to keep holding things tight this year as a system. Our ambition is to move towards more outcome-based contracting arrangements, but we're not there this year. And when you look at the performance report, we've got a performance report that is a very traditional performance report. I'm sure Amanda will talk about this in her overview, but we want to move to much more focus on outcomes, not outputs and inputs. The reality is, though, there are a set of things that through the contract we need to be working together on, and we need to be holding providers to account on. The good thing is we've got a starting point where contracts have been signed, and so we know what the starting point is. And so having that really active dialogue, I think, through the year around risks as they emerge, because undoubtedly they will. There are challenges already around the level of demand. That's not unique to any part of our system. It's going on across the country, and we need to do some work to get under the skin of it. But I just think the test will be that we're able to raise these things in a constructive space, where we're able to work together to try and resolve them, not through a world where we are, taking out contract breach notices and ended up in arbitration, because that would be a massive failure of the system in this arrangement. So I think, Rob, the answer is, we've signed contracts. Actually, people know hopefully now where they are starting. There are some risks in the system, and we need to work together on those as we go through the year.
Yeah, thank you. Adrian, how do you feel about that discussion? You're on mute, Adrian.
Thank you. Well, that covers 80% of what was on my mind. But in taking your lead to be crisp and brief, I kind of did thumbnail a little bit my way through what we discussed. And Rob, the concern that you outlined was very much in our conversation. We do not want to find out in month 6 that we got a problem. So we were seeking as a committee assurance from Alison particularly that there were good and productive relationships between the ICB and the cluster and all of the providers, so that we will be working with real-time information. It has been difficult at month 1 because, as Alison says, the providers haven't got all of the codings through to know what actuals really are. But we have a sense that there are already volume variances, and we also think that there are efficiency promises which are not yet in line with the phasing that's required in the plan. So, even at month 1, we think we are facing financial management challenges, but action is in place, and Alison tells me that we continue to have meetings of the finance community, providers and ICB to team-based problem solving. So, whilst there isn't a system control total that's helping us this year, actually many of the pathways that we put in place to get either out of recovery or progressed within recovery remain in place, and we'll continue to oversight that on behalf of the board at Finance Committee.
Thanks very much. Look, that was a useful discussion, and thank you everyone for the timbre, the tone of the discussion, which I think is really helpful. Chris Foster, on to your committee, please.
Thanks, Rob. Population Health and Commissioning Committee, another committee with a mouthful for a name, met for the first time last week. Adrian's reported that we had a first look at the strategic ambitions submission, which we discussed a few minutes ago. In addition to that, we also looked at plans for performance reporting. We looked at population health forward planning and had a very, from my perspective at least, helpful discussion about how we were to keep properly abreast of something which isn't in our committee title, but is a very important part of our brief, and that's place. And what information and reporting we needed that wasn't discursive, but actually helpful to us in the assessments which are going to need to be made in the coming months and years. There was nothing to bring for escalation to the board.
Thanks very much. And under this item, folks, we also have the cluster performance exceptions report, which we can take as read if you're happy, Amanda, and see if there are any questions or comments on what you and Chris have said. Or did you want to add anything, Amanda, to draw to our attention beyond the papers?
There was nothing specifically I did, but let me hand over to David, because this is still the very traditional performance reporting, although it's my team that put it together. David was going to speak on this part. When we get to the new style performance reporting, it will be much more of a joint effort.
All right. Again, David, we'll take them as read, but if there's anything you want to highlight for us, please do.
I was just going to say what Amanda said. So Amanda's incorrectly named on this. So colleagues, just as you can see, it's a traditional paper, but we wanted to make sure that whilst we're doing the transition, we are keeping across all these key areas of performance. We know what's happening, and so it's a very traditional report, as you will have seen. But that's because that's where we are in the cycle of our maturity and where we're developing our different performance metric reporting methodology going forwards. So there was more I could say, but I won't do that, Rob. So let's take questions by exception if anybody wants to dig into any of the performance metrics. They do, I should say, this probably throws it somewhat as well, which is that it's reporting to the end of March, because that's the last report data recycle that we've got, and aligned with the timings of coming into this meeting as well. So it is very much rear view mirror stuff, but happy to pick up any particular points.
Are there any questions, please? No, thanks very much. Can we? Oh, sorry, there's a hand gone up. No, it's Adrian. Yes, please.
You can move past it quickly if you like, Rob. I mean, I'm sure you're in the detail, but the number that just jumped off the page for me was that 62-day cancer number for Salisbury. I mean, I know the actuals look pretty much the same as the rest of the BSW patch, but as a variance to plan, it's just 17%. It's a big number. Is there anything going on there that we should be bothered about?
Good question. John?
Yeah, I haven't got the details of Salisbury's position, but when we were at the group board in shadow form last week, because we're just moving to the full group board, 62 days was picked up across all three providers. So we're going to do some deep dive work on the generic approach to 62 days. I think what's happened is that because we've all been doing a bit of recovery work on cancer, we've been chasing very hard on faster diagnosis standards. So you can see on the charts and trajectories that we've moved quickly to improve on that front. I think we lost a little grip and focus on the end of the pathway. So some correction work underway. Simon Setti is leading for us on elective recovery across the whole of the group and doing a really good job. So I think you'll see us bring some significant focus to that target and hopefully get some improvement over the next couple of months.
Thanks very much. And maybe we can just have an action tracker point there that we ask that your committee, Chris, gets a report on that and gives us some assurance on that for the future. It's a good one for us just to make sure that we keep a track of. And then finally, the Quality and Population Engagement Committee. I don't think you've met yet, Caroline. I think you've got your first meeting this month, but is there anything you or Sheila wanted to report to us?
I was just going to give you a quick summary of what we will be discussing to whet your appetite. So the first meeting's on Wednesday, 17th of June, and in the first meeting we'll be looking at the 3 legacy quality reports from the 3 ICBs with an exec summary, highlighting any safety or quality concerns, and then we will be bringing the following meetings we'll have a single report. We'll also follow up on the system quality groups, but they're staying as they are at the moment, so the local 3 groups, and looking at any issues escalated to the regional quality group. And then obviously it's quality and population engagement. So we have got a section on our meeting on Wednesday to discuss how we're going to be reporting and looking at that area of our work. And finally, just to say that the annual reports that report to quality committees across the 3 ICBs, we will be having a couple of special extra meetings, which we will invite the board to in July and October, where we can look at the 3 ICB quality reports and give them a bit of time for discussion. So watch that space. I don't know whether you want to add anything, Sheila.
No, you covered that beautifully, Caroline.
Thank you very much. Any questions or comments? Don't see any, so we'll note that. There are no items for information, and I'm not aware of any other business, which means we're due for our next meeting on the 16th of July. Thanks very much for a good meeting. That felt like a proper ICB meeting rather than us being in a period of transition. We've started to get on to the work, as it were, of being a strategic commissioner. And thank you for your highlight report, Jonathan, and what you set out to us, the work that's taking place, but also what comes next. And I think we've had a good discussion on your paper, David, on strategic ambitions, and thank you very much for the comments, John and Matthew and everybody, about looking outwards onto that. I thought that was very good, and good committee updates. And I think that discussion that we've had about making sure we're aligned between providers and commissioners as the year goes through on finances is a very important step to make this new system work. So I don't know if you have any other reflections, Jonathan, on the meeting, but I thought that was a very good first business meeting for the ICB.
Absolutely agree. Thank you, Rob. Yeah.
All right. Well, look, we will reconvene at 10 past for the part 2 meeting. I know we're finishing 5-6 minutes early, but just in case there are people joining us for meetings, so you can have a slightly longer break. You can have a coffee and a biscuit. Not just a coffee. For those of you returning, I will see you at 10 past 2 for the part 2 meeting. Thank you very much.
Cheers, Rob.
Thanks.